Mark, it's great to speak with you. Can you just give me the highlights of how you've been involved in global health?
Nice to be with you, Tom. I guess the easiest summary is I started at NIH doing clinical trials in Africa. President Bush wanted to do something big on HIV, turned it to Tony Fauci. He and I were working together. He and I put together the plan with some others on what became PEPFAR. I then ended up running PEPFAR after having been one of the architects. Then ran the Global Fund to fight AIDS, TB, and malaria. Now a professor at Georgetown working on supporting countries in Africa.
Terrific. So you were the first PEPFAR director, right?
There was one before, Randy Tobias. As Randy said, I was driving, but you were telling me where to go.
Yeah.
He was tremendous. We are very fortunate to have him. And it's one of the reasons we succeeded.
What years were you in charge of PEPFAR?
Technically in charge March of 2006 through January of 2009.
What years were you in the leadership of PEPFAR?
Since before it was PEPFAR.
Until 2009. So when was it? It was the State of the Union address in what year?
2003, but before that there was the Mother and Child Initiative. So that was actually 2002, the summer of 2002, that Tony and I also were deeply involved working with the Department of Health and Human Services putting together. When that was announced, which was a $500 million 5-year initiative to reduce mother-to-child transmission by 50% in the 14 most impacted countries in the world. President Bush said, that's a nice start. Now come back with something big. And that led to, based on experiences we had working in Uganda, principally seeing how you could actually deliver antiretroviral therapy by motor scooter to people in their homes, and people in villages that had no running water and no anything, knew their CD4 cell count and viral load.
So in a way, the maternal to child program gave birth to PEPFAR.
I think it was the midwife. Without it, we would not have learned what we needed to learn to move quickly with PEPFAR. The interagency process, I'm not sure PEPFAR would have ended up at the State Department if we didn't go through the Mother and Child Initiative. But many of the things that we now take for granted, operating plans, all that all came out of the Mother and Child Initiative. We learned a lot. I would not have moved as quickly without it. Had we come up with PEPFAR first, which is what President Bush really wanted, we might not have succeeded.
So big picture, 20, 30 seconds or less, what are the greatest things that PEPFAR is achieving?
So the greatest legacies of PEPFAR, I think, are lives saved, 26 million lives saved. Second is building of an infrastructure that is capable of delivering antiretroviral therapy and people taking drugs every day down to villages, very remote villages. That infrastructure is the backbone off which health will be provided in Africa. The third is a restoration of hope. It's impossible to describe how hopeless an entire subcontinent was. And if you're hopeless, you're not thinking about economic growth, you're not thinking about education, that transformative hope. And the three together supported countries to own their own response to HIV and therefore think about how they own many other parts of their communities. And it's really propelled a very exciting change in Africa, I think.
26 million lives saved, the ability to give treatment to an entire country in every village, and hope. Not bad.
It's not bad. It's not bad.
What was the hardest thing to achieve? What was the biggest barrier you had to overcome in the US and the biggest barrier globally?
The biggest barrier in the US was the interagency process and the infighting that occurs, which we got over singly because of President Bush and the people around him, and because Congress was willing to go along, not more than go along, strongly support in a bipartisan way. The biggest problem in countries, I would say, is we sprung it on them. So they didn't know. No one knew until the day of the State of the Union. The countries didn't know. And we were saying, because we meant it, that this was going to be a country-owned program, but we just announced which countries and what their goals were going to be, so it didn't sound so country-owned. So we spent 2 years building that trust that this, in fact, was intended to be country-owned, and it had to be for national scale. But I think that was the biggest challenge. There were many, many tactical implementation challenges, but that was the biggest challenge, I would say.
I would venture to say that today PEPFAR faces the greatest challenge since it was launched now 20 years ago. Just outline what is that challenge and what's at stake.
The challenge is one of our own making. So one of the things when PEPFAR was created, it was never intended to be forever. That was why we were supporting countries to build national capacity. We had started what people call partnership compacts. I met with President Zuma. We had an agreement 5 years and we'd be out. We were supposed to be in transition mode throughout the last 25 years. Now, because we did not do that, and the international system has not done that, we're seeing very dramatic and rapid cuts that will be difficult for countries to have the effective transition we could have if we'd begun it 25 years ago when we should have. So I think that is the challenge that is faced. And to be honest, in part, it's one of our own making.
One of the critiques of not just PEPFAR, but the Global Fund and HIV funding has been that it has replaced country dollars, that country dollars that were or would have gone into these fields aren't. Understandably, countries are resource constrained. Gavi has taken a different approach with kind of graduation approach. Some of the World Bank programs have a time slice funding approach where countries increase from maybe 5 or 10% of total costs, gradually up based on their income level. We are where we are now. What could be done now to have a more responsible trade-off so we don't lose the treatment systems, the lives saved, and the hope?
So what could be done is something I'm spending all my time on, which is to support the countries to have transition plans, to develop transition plans that where they could, about a dozen probably within 2 to 3 years, not require external financing. And then others will take a little bit longer. It's a process we tried to initiate. Eric Gooseby tried to expand, but it fell off because there's a sociology of institutions which is self-preservation. Even Gavi is in many of the same countries. The World Bank is in many of the same countries. The Global Fund is in many of the same countries. So we're not very good at this. What we could do is understand that we're not supposed to be around forever, these organizations, that we're supposed to be supporting countries, and that we can still do that. My own guess is that there are so many inefficiencies in the system now because of the parallel systems, the massive data systems, which there were reasons for creating them then, but we should have been scaling them down and switching to things that are more cost-effective, supply chain systems, technical support systems. I think some of these countries could rapidly move within 2 to 3 years to not require external financing. Again, others will take longer. So what we can do is support them to achieve that and then to stay in the game with them. But I would argue that we want to transition from external financing. They want to transition from external financing. They don't like the aid model either. But what they want to transfer to and what is good for us to transfer to is a new relationship built in private sector investment, opportunity together, technical exchange, whether it's academic or private sector, so that we can grow, learn together, and actually solve problems together. So it's a transition from external financing, but to a different model of how we should be engaging with countries anyway, from the beginning.
For some countries, Mark, there really is a fundamental economic problem. Let's just do very simple math. Suppose a country has a 10% prevalence of HIV, which is the case in some places. And just for round numbers, let's suppose it costs $100 a year to treat a person with HIV infection. That's $10 per capita, 1 out of 10, 10%. I can do that math. $10 per capita. That may be larger than their primary care health budget. That may be more than they're spending per capita or as much. That doesn't seem really plausible as a route forward. How do you get sustainability with that kind of cost model?
Well, there are a couple of ways to do it. The ongoing costs for treatment now are manageable for large numbers of these countries. Not all of them. Malawi can't do it. Cameroon can't do it. But South Africa, Kenya, Nigeria, Angola, many countries can. Namibia, Botswana. So it's working with the ones that can so that they have the transition in place and that you learn then in part two things. One, how other countries could follow a path. Their path's going to be completely different. The process is the same, but the path will be different. And then what else you need from the multilateral system and for how long. And so you have transition. Some countries can do 2 to 3 years. Some countries can do 5 to 7. Some can do 7 to 10. And then there'll be a bucket of humanitarian that will never get there. So the math gets better once you start taking out the systems that have been put in place that are too expensive and unnecessary, and letting them be local systems, which is good for the local economy and local environment as well. But the math is complicated in some places, but in many places it's not, and it's a matter of time. It's a pathway of time. Countries also have to increase their revenue, and there's health economy opportunities, which is where the private sector comes in. But they also just need to dedicate. Your comment earlier that we've replaced health money is in part true, but that's because they were spending money on other stuff. If you have money coming in from external sources, of course you're going to spend it on something else. Now they have to shift. They have to buy, and they have to figure out how to balance their systems. They also have to figure out how to raise revenue, whether it's sin taxes on alcohol and tobacco and things that cause health problems, which is going to burden their health system for the long term. And many countries are actually exploring that. I know it's something you feel very strongly about, or other mechanisms that are possible that can lead to sustainability.
What do you mean when you say that the private sector will be part of the transition plan? What does that look like? Give me specific examples of how that can be helpful and productive, constructive.
It's going to be different country by country. And there are some countries where the private sector has tremendous opportunity right now, some places where they don't. But for example, there are diagnostic centers in Ethiopia, in Nigeria, and private hospitals in South Africa. There are private hospitals doing allogeneic bone marrow transplants in Kenya and in South Africa. Private. Now, those are for wealthier people, but it's a lot better. You can get an MRI down to $75 or a CT scan down to $60 in these private centers. The wealthier people can do that. And it's a lot less expensive than flying to either South Africa or India to get your MRI. So there's private sector investment that can build an infrastructure for growth as the country is growing into a stronger health system. There are also opportunities to just make money off things like better procurement systems, better supply systems, better pooled procurement mechanisms. Not large amounts, you have to limit, you have to cap it. But there are investors that will go in to get a 2 to 3% return. They'll be far more efficient than the systems we currently have. But we don't engage the private sector on their terms. We don't support business plans. We just go to them and say, fund this. We want this done, fund this. It doesn't work that way. And you have to align interests. There are also things you can do with the private sector that does need a healthy population. Ford Motor Company and Anglo American were among the first providers of antiretroviral therapy in Africa because all their workers were dying. That's not good business. So you can have companies that are funding, for example, the National Health Insurance Scheme, or ensuring that their workers have national health insurance or have private health insurance to alleviate the National Health Insurance Scheme. You can have private sector diaspora funds that could support national health insurance premiums. They'll never give money directly to governments. There are ways the private sector can engage in multiple ways. There are also ways to pool debt across countries. So if you take countries that have credit ratings of C, if you pool 15 or 20 of them, their credit rating can go up to an A or even a double A because you're limiting the risk. You can have mechanisms, facilities that could be multilateral that private sector can get access funding for with a first loss that a government will take or a multilateral will take to invest in various things related to health or to education or to other parts of development. And these things can create a lot of jobs. Another area is clinical research capacity. That's a multi-billion-dollar backlog business that needs genetically diverse participants. There's a great opportunity there. So we have to stop thinking about aid, which the countries don't want either, and start thinking about if we reimagine what the future should look like, not based on what we've done the last 25 years, not criticizing what we've done. The infrastructure had to be built, the platforms had to be built, countries had to evolve, but what we do for the future and let countries help drive that, and let the private sector help drive that, we can have a very different world that is much better for everyone.
Let's change tack a minute and talk about primary healthcare. I believe that strengthening primary healthcare is one of the most important things we have to face in the future. It's a key lesson from the COVID pandemic. It's a way forward, as you were talking about, being less separated, more integrated, more efficient, more country-owned. And yet we have essentially 50 years of failure after Alma-Ata. You can count on one hand the lower income countries with decent primary care systems, and even those are really not meeting their potential.
Yeah.
So what could we do so that primary care isn't, always the bridesmaid, never the bride, so that primary care actually gets something beyond lip service, which is basically what it gets all over the world. I mean, just take the US.
Yeah.
A great primary care doctor, after 25 years of dedicated service, will make less than half as much as a newly graduated surgeon.
Yeah.
So if we ask, well, why aren't people going into primary healthcare? It's very simple math.
Yeah, and nurses will make even less, and midwives, and the people who actually do the most important part of primary care, which is preventive care, so that you don't actually end up with diabetes and hypertension and drug addiction and all mental health, which we don't do well even when we build primary care systems. So I believe the solution here is to involve communities as you're designing your health system. And this is, I've seen work. And I think as we think about transition plans, as the heads of state I'm working with are thinking this way, you have to go down to the community level, because the communities will identify efficiencies, but they'll also identify how to strengthen their local systems. If you give them a role in solving problems that links to government, you can actually have rapid acceleration in basic primary care. The other opportunity is technology. Technology can turn basically a primary care worker, a community healthcare worker, into a primary care doctor with good technology, and also focus on the preventive pieces. And then I will bring in the faith community, because the faith community is quite good at primary care in a comprehensive way that involves prevention, food, nutrition, education. And so you have to bring all these pieces together. What we don't do well is link community systems to the healthcare system, even when we have a community healthcare worker system. And we've done a lot of work in Eswatini and Kenya that overcame that linked the formal health sector to the community sector, which then led to community solving problems that the health system then solved. It's really dramatic when it happens. So we have to think about health not as ending in a public health clinic, but as going deep into the community. And then you naturally start from there and focus more there than on your tertiary care hospital.
So let's get really specific. Imagine we're in a community and we say, okay, we're going to empower the community to help design and engage with and implement primary care. What does that specifically look like?
So let me give you a great example, because this is some of the work we were doing in Eswatini and Kenya. We went out and met in a clinic, not the lowest level village clinic, but the next one up, clinical center. And we met with a young, dynamic, fantastic doctor who ran the center. I said, how do you use your community advisory group? And we had members of the community advisory group there. And the answer was, well, we tell them what we need them to do and then ask them to go out and do it. As he was saying it, we all started laughing. It was like, huh. And the community people said, we have ideas too. Have you ever asked us for our ideas on how we could actually strengthen this clinic into something much better and much stronger and reach more people? And that conversation led to tremendous improvement in outcome. That's how you do it.
Give me some examples. What are some just 1, 2, or 3 specific changes as a result of that process?
As a result of that process, young women were coming in because they realized...
What were the changes that were made that resulted in progress?
So a couple of them were changing the hours of when the clinic was available so that people could come when it was meaningful to them. Another was working with pharmacies to provide services to young men, because young men will never go to clinics, but they will go to pharmacies because they kind of hang out, and no one thinks they actually have a health problem because people hang out at pharmacies. So they started delivering service. They started delivering condoms. They started delivering medication, including prescriptions and antiretrovirals through those facilities. In some places, they did kiosks where people could go get their drugs from a kiosk rather than having to do it while the clinic's open or having anyone see them going to the clinic. So communities start to solve their problem. They also start, and this is one of the most exciting things, they started to link health to other things important for prevention: clean water, food and nutrition. They started bringing in these pieces, and not with health money. They started then, as communities, going to the government to say, hey, we need clean water if we're going to solve these health problems. We need to get that garbage dump not next to our water source as another problem, which is also part of our climate issues. And they actually do think about climate at the community level. And they start fixing those problems. So then you start drawing money in from the community of the Ministry of Sanitation that also supported the health work. So they saw that really is important for prevention of disease, not just treatment of disease. In other places, they fixed potholes because the boda riders were complaining about the potholes and all the accidents that were being caused. And they had the Ministry of Transportation come in and fix the potholes. That's what can happen when communities start to engage. And what's really exciting is the communities, when they actually feel like they're not just being like that doctor was doing, telling them what the clinic wanted, but participating in solving the community's problems, you start to see a multi-sectoral response, and you start to see government responding to the people. We had a governor in Kenya put it very well. He said, this is our constitution. There's no way we sitting in a capital are going to figure out how to solve the problems at a community level in the way they need to be solved. And again, it's not empowering them because they have the power. It's just engaging in a different way that makes problem solving occur at the community level with everyone engaged, not just the so-called people in charge.
Let's take a different tack for a minute. Let's talk about not just the moral imperative of PEPFAR, but also the strategic imperative, how it is not just soft power, but something that changes the world, not just in the health sector, but much more broadly.
Yeah, so I think that hope has a lot to do with it. Hopeful societies tend to look at the world a little bit differently, and healthier societies, and this has actually been documented. We haven't spent a lot of time documenting the non-health impacts. The lives saved are important, but Kaiser Family Foundation found that countries where PEPFAR was operating versus countries that didn't had a 3% higher GDP growth because that healthier. It makes sense. You have a healthier population. Healthier populations are more productive. You also need a healthy population for anyone to want to invest in your country because you need a healthy workforce, healthy, educated workforce. You call it soft power, but it's actually hard power in many ways. Their ambassadors, Mark Green, one in Tanzania, said the only reason he ever got meetings with the president was because of PEPFAR. We weren't doing a lot in Tanzania otherwise, and they didn't. He had no role. There was no reason for the president to meet with them until PEPFAR showed up, and he was meeting with the president and the prime minister very regularly. There are Senators Frist and Daschle, Senator Frist was the majority leader. Senator Daschle, when PEPFAR was first authorized, looked when they were out of the Senate through the bipartisan policy committee or council, I can't remember. But they actually did a formal survey and found that countries where PEPFAR was operating had a higher, much, much higher, like 20 percentage points higher opinion of the United States than countries where PEPFAR wasn't operating. And I've seen that in real life. I've seen the immediate influence of PEPFAR. The president of Namibia, the first time I met with him, who's the person who led the independence movement, Nujoma, said, we hated the United States because of the side you took on apartheid. But you're the only one here supporting us in our hour of need when our country could disappear. We now love the United States of America. And I now hear every president I've ever heard in Namibia talks about PEPFAR. Even when no one asks them about it, they say PEPFAR is one of the greatest things that ever happened. And this is why we like the United States. Unilateral withdrawal is giving up on all of those gains. But it's also ceding the field to China, to Russia. As soon as Russia doesn't have Ukraine anymore, they were investing in Africa. They're going to go right back to it. The Arab countries are investing heavily in Africa. 1 in 4 people in the world are going to be African in 2050. 1 in 4 people in the world. And the vast majority of young people are going to be in low and middle income countries. That's where jobs are going to be. That not jobs, but that's where economic growth is going to be. That's where our marketplace is going to be. That's where our opportunity for technological advance is going to be. We have that opportunity because of the investments we've made the past 15 years. Most countries in Africa would pick the United States as the country they want to work with. We risk losing that. So do we want to lose all that, including all the gains that have been made? Or do we want to build a successful transition that allows us to shift to the good relationship for us for the future, which is a private sector investment focused for our goods and services, for our economic growth and development, but also for theirs in a mutual way? Or do we want to give up the whole field to other competitors that could replace the United States?
When I think of the Global Fund, there's been an evolution. And over recent years, it's done a greater and greater proportion of procurement, which it does well, and less program. What was your experience in your 4.5 years at the Global Fund?
So the Global Fund is hugely important because it's the only other way the rest of the world really contributes to HIV, TB, and malaria. No other country has a bilateral program like PEPFAR or the President's Malaria Initiative or the Neglected Tropical Diseases Initiative. Some have neglected tropical diseases or mold, but that's the way the world, most of the rest of the world, contributes to global health. And that means US taxpayers pay less. But it also brings the whole world to the table. There was this move while I was at the Global Fund to shift procurement to the Global Fund and have the US do more of the community strengthening, the health system strengthening. I never really thought that was a good approach, to be honest. There should be a pooled procurement mechanism. We created one while I was there called WAMBO, which had actually grown into what it should have been, a public health good, Amazon.com basically for health commodities. We might have had a very different outcome during COVID. I think I want to turn this into a bigger question, which is, what is the current role of multilaterals, especially in a world where we're going to have transitions of a lot of financing occurring by countries themselves, a lot of that happening? What do we still need from the multilateral system? And it's not what the current multilateral system provides. It's also a very expensive system. So I believe deeply in them. I mean, was involved in the beginning, early days of the Global Fund. I was on the board for a long time. I ran it. I still believe deeply in it. But out of these transition plans from countries, I think will emerge, what do we still need from the multilateral system? And do we actually need a global pooled procurement mechanism, or do we need regional pooled procurement mechanisms that link? What kind of financing facilities are actually useful to countries? What kind of financing facilities will drive private sector investment? Dan Zellico, who you might know, has a great line, which is the World Bank and financing institutions should become McKinsey. They should be there, not JP Morgan. They shouldn't be trying to drive private sector investment. They should be trying to support countries to have enabling environments for the private sector so that their economies can grow. Similar in health, as we think about what health multilaterals should do, I think the first place is to look to the countries. What do the countries need and want after they've gotten to where they need to be? A little bit like after a community looks at what it needs and can do to solve their health problems, including clean water and nutrition, what do they need from the government? We need to bump that up layer by layer. And I think we need a complete reimagining of how the multilateral system functions. That doesn't mean creating new institutions. The last thing on earth is we need is another global health institution. We already have too many, but there is an opportunity for consolidation, maybe closing, but also reimagining what is needed now, which is not a criticism of what they've done, because that's what we needed to do for the last 25 years, but that's not the same thing we need for the next 25 years.
One of the things that the current Trump administration has proposed is that the U.S. match in the Global Fund go from 1 to 2 to 1 to 4, so that U.S. would be paying 20% rather than 33%, if I got my math right. Right? Yes.
That's correct. That's correct.
And that actually doesn't seem so unreasonable.
It's not unreasonable. I mean, it's a little bit of the approach that's been taken with NATO, and good announcement yesterday that countries in Europe are going to increase their defense spending. But there are trade-offs for that too, then what it could suffer. Different countries pick different things to invest in. The US invested largely in global health. That was a big thing for us. So we were doing a third. We do a third of other things. So I think that's But I don't think it's unreasonable for us to be at 20%. I don't think you should just randomly pick these things. We should look at where are we going to invest, where,
and there's also a transition
there's a
that's
transition
needed. You
phase
can't
to it.
do things overnight or you'll have big
Right.
gaps. That's one of the key
Which
points.
gets back to the transition. How do you plan for successful transition? Combining both multilateral and bilateral programs. But in principle, it's not a bad thing. It's just getting to it.
You know, Mark, the first time I heard you talk, it was at the start of PEPFAR, and you were being attacked over the abstinence programs, which, basically don't work very well. You gave a very smooth answer. I was impressed. But if you had PEPFAR to do over again, what would you have done differently?
I can tell you the things I would have done differently. I would have advanced partnership compacts earlier because we started them too late, which would have accelerated the transitions we've been talking about. That should have started then. I would have been much more careful about data systems and watched over more, which I didn't know until it was too late, that we funded so many universities and US-based institutions that held the data themselves rather than sharing it, and that spent far too much money on the data system. I would have, which we had to create, the supply chain management system, because our biggest worry is that we were going to not have enough supply for the things that were needed, would have insisted on turning that over to some local group within a period of time, as we did with large treatment grants. I would have accelerated the localization approach, which we started, which had to do with partnership compacts. We turned large volumes over to local organizations. We did things to stimulate more local organizations, partnership group. We should have done a lot more than that, a lot more of that. On the policy stuff, look, we did in the 2008 reauthorization, all of that language went away. But as Jim Colby said during one of the appropriations committee, he was chair of the House Appropriations Committee, as these things always happened every year in appropriations in the House. We never do in the Senate because the Senate didn't even bother with the hearing. They were like, you tell us everything we need to know. We're just going to give you the money. The House always got down to abstinence, fidelity, condoms. And Jim Colby just said, look, we can keep having this conversation, but if we don't have this earmark for now, there is no PEPFAR because we won't have bipartisanship, and I can't get my caucus to vote for it. So, in the end, as Ted Kennedy said, compromise, but never compromise your principles. I don't think that smooth answer was just to get out of it was to never compromise our principles, but to compromise where we needed to make sure we saved 25 million lives, built a health system, and created hope.
So if you had one suggestion for the Trump administration, what would it be?
Focus on successful transitions that meet safer, stronger, more prosperous.